So my name's Cliff Miles. I'm a transplant nephrologist, and I work with the transplant program here in Omaha. And I'm delighted that people are tuning in. I know it's kind of the end of the day, and it's on a Saturday, and I appreciate people making the effort. Also, as a warning, I found the laser pointer tool in my presentation, so watch out. So, I didn't know what to say about this. I wanted to disclose that I do participate in a research study with Talaris. This talk has nothing to do with it, but I saw that they were involved with one as a sponsor for the Connect, so I thought I'd throw that out there. Otherwise, nothing to disclose. I think what we'll try to cover here, hopefully in about the next 30 or 32 minutes, so we have some time for Q&A, are these items. I really want to talk about the benefits not only of kidney transplantation, but of what we refer to as preemptive kidney transplantation, starting with the definition. Talk then about barriers to receiving a kidney transplant prior to dialysis, and then frankly, some of the controversies that surround it, because I've given a similar talk in the past, and some of it's, I don't know if it's changed or if I'm just getting older, but there are some things about it that I think we should dwell on for a few minutes. And to sort of start kind of this proverbial 10,000-foot view, I think this is one of the issues that we deal with kidney disease in general in this country, and that is it's just sort of an epidemic that continues to grow. And if you kind of extrapolate the number of people in this country with kidney failure out to where we are now, we're really close to about 1 million people. And that's if you just define kidney failure as being either on dialysis of some form or having a kidney transplant. This data is from the United States Renal Data System. And I have a couple slides. It's a public website, great wealth of sort of statistical information about kidney disease. But I think it's important to remember, keep in mind that the number of people with end-stage kidney disease is really just a small fraction of the people in need of therapies like transplant. So the NHANES project, I guess, has been going on for a long time, and it's an effort to follow a large number of people in this country and sort of like observational study, like watch what happens to them, collect demographic and clinical information, and then like events, health events. So I actually don't know how many people. It's tens of thousands, if not hundreds of thousands of people in this country, and it's really been a useful wealth of data on Americans. And so again, the USRDS worked with NHANES to find some stuff out, and so the estimate is about between 14 and 15% of the population has chronic kidney disease of some form, and that's a huge number if you multiply it times the population. So nearly 50 million people would be the estimate. Of that number, if you just focus on people with significant protein in their urine or quite low kidney function, like stage, if you're familiar with the stages, like stage 3B or 4 chronic kidney disease, those are people that are really at high risk of progressing to end stage. And that's, so it's a smaller number than 47 million, but it's somewhere between 8.5 and 9 million people. And to me, that's really the scope of the sort of problem. How many people are really talking about that need therapies like dialysis, like transplant, sort of coming in the sort of near future? And so these are basically kind of overview of the options of treatment for kidney failure for end stage. And probably people here are aware, hemodialysis, peritoneal dialysis, and transplantation. And then there's in-center and now more and more home hemodialysis, and then live donor and deceased donor kidney transplantation. Kidney transplant is generally thought of as the treatment of choice, and I sort of think of, I'm sort of a simpleton, I sort of think of 3 reasons why that is. One is that generally people can expect to live longer if they have a kidney transplant. So again, from the USRDS, the blue lines are the life expectancy with a kidney transplant compared to the sort of gold lines, life expectancy on dialysis. And then it's shown here displayed over different age groups. The point being that kind of no matter how old you are, for people who receive a kidney transplant, the expectation is that they are going to live longer. Quality of life has been looked at a number of times by a number of groups and it's consistently shown that across the various sort of realms of quality of life, transplant dominates dialysis from the quality of life standpoint. And I think the reasons maybe are I don't want to say they're obvious, but generally easier to travel, easier to hold a job, interact with family, fewer dietary and fluid restrictions, and then for pediatric patients, sort of restoration of growth and development and things like that. So quality of life is another advantage. And then we don't always talk about the cost of healthcare, although maybe we talk about it more and more in the last 5 to 10 years. But again, so this is over time, cost per patient per year to whomever, and obviously Medicare shoulders the cost of a lot of end-stage kidney disease, which means we all share in the cost of this. So the gray bar is the cost per patient per year to take care of somebody with a kidney transplant. Red is peritoneal dialysis, and I think this is navy, some color like that is hemodialysis. And so there's a significant difference. Now, one caveat is the first year, the year someone gets a transplant is expensive, and most estimates are in the $125,000 for that year. But every subsequent year costs significantly less for us to take care of someone with a kidney transplant on average. And so when you take those three sort of things together, people are likely to live longer, they're likely to live better, and it actually costs less to do. I think it's pretty well founded to say it's probably the treatment of choice. And a couple snapshots of people from, I don't know if you call it pop culture or whatever, that have received kidney transplants and maybe and have been public about their life before and after kidney transplant. And so one of the issues then is, so why don't we transplant everybody? It's a great question, and hopefully someone wonders that. This is the number of kidney transplants done per year over time in the United States, and a couple comments I would make about these numbers. So the biggest of which is that there's been some increase here in the last couple of years. I think I should know this number. I think it was about 27,000 for 2021, which is great. That's a lot of kidney transplants. But I just got through telling you that there's probably several million people that would be considered in need of a kidney transplant. So we're falling short, to say the least. Generally about twice as many deceased donor transplants here in red as there are living donor transplants. And then so I started my career right about here. Hopefully you all thought that I started right out here, but that's not true. And this is like the first decade of me doing this job is sort of kind of depressing, because remember, the number of people with kidney failure was going up, rapidly, linearly during that time. And here we sat doing kind of the same number of kidney transplants. So it has started to improve recently, but it's still, again, like falls short of the real need. So I want to talk a couple slides about paradigms. And this is sort of the way probably providers are taught. Maybe it's the way people that work in clinics are taught. Maybe it's the way people who are outside of medical care are taught about kidney disease, is that there's a whole bunch of people who have chronic kidney disease, growing number, we talked about, and there's this sort of focus, okay, my kidney function is getting worse, I need to prepare for dialysis. And I'll bet a lot of you are familiar with the fistula first push that was going on for a while. So you prepare for dialysis, start dialysis, and then you get to dialysis and someone says, oh, you should think about getting a kidney transplant, so you go get a kidney transplant. Many of you know that's not quite that easy, because to get transplanted, there has to be some way you get referred to a kidney transplant hospital like ours or anywhere. And then the transplant center is going to evaluate you, and that has its pros and cons, and is in and of itself a entire session we could give. And then you're added to this thing called the wait list, which doesn't sound that great. And then you get yourself to kidney transplant. But remember, with so many people that need transplants and relatively very few transplants being done, that's what the wait list is. All these people that have been told, yes, whatever, we agree you would benefit from a kidney transplant. That's the good news. The bad news is there's always other people that are sort of got here first and are in line, and you're going to get on the waiting list. And so as that has grown, the median time that people wait is now up to like 4 years. And it varies a lot across the country, which again is another thing we can have a whole talk about, but the median across the country is about 4 years. So that arrow is pretty long from when you're added to the waiting list to when you get your transplant. There's been a number of studies in the literature over time that have shown that the longer people are on dialysis, the sort of more bad things can happen is one issue. But also, interestingly, it impacts how people do after their kidney transplant. So people that have been on dialysis longer actually fare worse after their kidney transplant. I couldn't find any good like pictures from these articles, but I guess that's just the point, is that interestingly, so if people, one group of people waits 1 year versus somebody who waits 3 or 4 years, the group that waited longer has more trouble. They have more rejections, and they have more, they frankly, they die sooner than people that experience less dialysis. So what maybe we should think about is doing this a little bit in a different way. And I've tried to model some of my own practice, but also our transplant programs practice around this, which is to try to, I guess I would think of it as getting upstream and saying, well, maybe it's not fistula first, but maybe it's sort of transplant first. Get people who we think are at high risk of progressive kidney disease, lots of protein in their urine, low kidney function, but not so low that they're actually needing to start dialysis, and have them think about kidney transplant and be referred and be evaluated and be added to the wait list, and maybe get them transplanted before they ever actually have to go to dialysis. And that, in a nutshell, is sort of the definition of preemptive kidney transplantation. And so some of this is intuitive, and yet there's actually been studies that show that it's better, but you can sort of think about it. If you don't have to go get either a peritoneal dialysis tube inserted, which is a surgery, or go have a fistula created, which is a surgery, or go have a dialysis catheter put in, which is associated with all sorts of evil, then that's probably good. But there's some other interesting stuff. That's that people tend to not have what we call delayed graft function, where they the new kidney doesn't work right away, and you may need dialysis or something while you're waiting. And then stuff that's harder to explain, like why is there less rejection in people who have never had dialysis? And so just a little bit of sort of data to back this up. So these 3 lines, this is patient survival after kidney transplant. And what it's showing is that people in the red line had the sort of, they were broken into thirds, and they say this is the third who was on dialysis but had the least dialysis time compared to, that must be black and green, I think, of those 2 colors. Those are the second third and the third third of amount of time on dialysis before they had their kidney transplant. As you can see, there's some separation out here, meaning that less dialysis was associated with people dying less frequently, if I said that correctly. But what's really interesting, this line up here is the people who never had dialysis. And so that's, and I don't know if anybody out there likes numbers as much as I do, but this would be considered a big difference in these sort of survival experience of people by amount of dialysis, with no dialysis being clearly the outlier, and the outlier in the positive direction. So this is, I'm going to dwell on this slide for a little bit. So the study is a little older, and I acknowledge that, but the concept here I think is great. So if you think of the top of the box up here as sort of normal, feel great, quality of life, functional status is whatever you want to call it, good, normal. So chronic kidney disease is not a picnic. I think they're starting to have symptoms. Maybe it's fatigue. Maybe it's the need, frankly, to go see doctors and go have blood drawn and have tests done, which no one likes to get poked and stuff like that. So the quality of life and functional status is decreased a little bit by chronic kidney disease. And then if you follow a sort of light blue line for individuals who start dialysis, that's a big deal. So you have to have some sort of surgical procedure to do dialysis, again, like PD tube or fistula or line placement. Often, with a hospitalization, not always, but frequently involves a hospitalization. And then people kind of get established on dialysis and they get used to it and they kind of get their routine back together and they plateau in this area, which is, so they're better than they were, but they're not back to pre-dialysis and they're not back to, I hate the word normal, we'll call it normal. And then they get a kidney transplant, which you have to have a surgery and being cut by the surgeon hurts and you're back in the hospital and you're getting your blood drawn. And so you go down again in your sort of functional status and you recover finally to out here, which I wish transplant was up here, but it's not. It's involved seeing people like me and having your blood drawn and taking medicine and things like that. So it's better than dialysis, like the studies showed. But you had to go through these two big divots to get there. So the red line is preemptive transplant. In sort of a broad stroke, you take out this chunk with the dialysis initiation. So you have surgery, which hurts, and you have to be in the hospital, and you have to get your blood drawn, you have to take medicines, but you only have the one big divot. And the mathematician in me wants everyone to see this sort of funny, I don't know what shape that would be. It's like a pair of fangs or something. But this area under the curve difference, this is all of the benefit from a functional quality of life standpoint that preemptive transplant is associated with. Excuse me. Same group, and I'll spend less time on this slide. The same group walked through basically a financial model of this because starting dialysis is expensive. Getting a kidney transplant is expensive. So if you could just skip the one and have only the transplant, it ends up being cost effective, kind of like we talked about earlier. But they actually walk through and put numbers to this and sort of prove that beyond just like the sort of concept hand waving that I'm doing. So again, older paper, but so the numbers will be different, but the concept would still hold true today. And so, sometimes things just seem obvious. If you have a therapy where people are going to live longer and have a better quality of life, that's going to cost less, that sounds good. So sort of like we compare dialysis to transplant, if you compare transplant to preemptive transplant, you again have these, another layer of benefit across these different realms. And so that's great, but then you kind of get to the reality. And so again, older data, but the relative benefit will be the same. So this study looked at a decade's worth of kidney transplants, and there were about 140,000 total that they looked at. Only about 17% were done preemptive. And it's harder because of the waiting list thing. I think one should expect that relatively few preemptive transplants are done from deceased donors. But even from living donors, less than a third of the transplants done during that decade were done before people started dialysis, which I think is really interesting. I would shout out to the PKD community that historically the performance has been a little better, but still half of people who had an identified living donor still ended up starting dialysis before they had their kidney transplant. So room for improvement exists. And so we all spend some time thinking about, so why is that? What are the barriers to having people go through this paradigm where they get to sort of skip out on the dialysis part of kidney disease experience? And I think to me, the biggest issue is just delayed recognition of chronic kidney disease. And that's not to blame patients, that's to blame all of us. Like as a system, there's just flaws. And it's people don't get chest pain or whatever. There's generally either no symptoms or vague symptoms or non-specific symptoms associated with kidney disease. And so it's harder to recognize, but it's becomes delayed. And then there's evidence of this, that even people who are known to have chronic kidney disease and reduced kidney function, there are delays in being referred and being seen by a kidney disease specialist. And this is impacted in a lot of ways, but some of it is disease education and health literacy issues. And again, that's not always on the patients. I think that there is plenty of evidence that healthcare providers outside of nephrology may not always be clued into the importance of referring someone with kidney disease to a nephrology clinic. And then really, to me, if you're talking about a barrier to preemptive kidney transplant, it's this failure to identify a living donor. And maybe I should have put in there, identify a living donor early enough to make a difference. So with respect to disease recognition, this data, again, came from that NHANES database, and then the USRDS worked with it to try to make this make sense to people like us who think about kidney disease. So I think this line here is sort of all comers, which isn't that useful. But see, the early stage of kidney disease, again, not many symptoms. What they have is non-specific generally. But look at this, like less than 20% of people with stage 3 kidney disease are even aware when they were surveyed that they had kidney disease. And if you jump up to stage 4, so these are people that to me need to be thinking about this, need to be making plans, need to be thinking about who could donate a kidney to me. You're just over half, maybe approaching 2/3 of people, which leaves a huge bunch of people who aren't even aware that they are in need. And then interestingly, even people who are on the brink of needing dialysis or transplant, still not all of them know that they have kidney disease.
10 minutes, Cliff. 10 minutes.
Thanks. So of the people who developed kidney disease, and this is back in 2014, so a quarter of them, just over a quarter of them, actually wandered in the hospital not knowing that they had kidney disease and left on dialysis, which is a huge number. And a pretty small fraction actually had seen a nephrologist, but not long enough to probably do any real good, dare I say. And then only a third, I guess I should say, actually had an established relationship, because I think it probably takes a year to really get some of this stuff thought through and planned out. And interestingly, just as an aside, including the Never group, are some surprises. So we as healthcare providers, at the very least, ought to recognize someone with diabetes is at risk of kidney disease. And yet a quarter of people who had diabetic kidney disease didn't know it until they needed dialysis, which I think is appalling, as Macaulay Culkin would say. So just a couple bullet points in case you didn't know. Someone can be referred for a transplant really at any level of kidney function. You can be listed at any level of kidney function too, which probably even fewer people knew. But where the 20 comes, a lot of people have heard of this GFR, creatinine clearance of 20. That's just to be eligible to accumulate waiting time on the list. You can be referred by yourself or by your primary care provider or by whomever. We actually end up referring some of our own patients, which is awkward. And then you can be on the list and be on hold, and you still accumulate waiting time in that position. And so to kind of get, I warned you that there's, I give this before I'd sort of be done with my talk, then we talk about Q&A, but there's a couple things I want to talk about real quick. So where is the controversy? So I said you can be referred at any level of kidney function, which is true, but can you be transplanted too early? And maybe it depends, but I would say probably. And so I guess if you start like at the extreme, is someone who wasn't going to live long enough to need dialysis, then transplanting them probably didn't really do them any good. And I think, if you get into the extremes, it becomes less interesting. So what about a little more nuance? So you have two individuals who have a GFR of 19. So they're stage 4, almost headed towards stage 5. They, to me, should really be in a mode of thinking about transplant, but also, what are they going to do? Dialysis if not. So if you take that person and they're eligible to be referred, they're eligible to be listed, and actually they would accumulate waiting time, so they could actually get either a deceased donor or a living donor kidney transplant. If you take them right away and transplant them, and they have an average outcome, and we can argue about what average is. I just said, let's call it 15 years for simplicity's sake. Then this is kind of when their kidney transplant is going to fail. If we pretend time is going from the left to the right across the screen. So if you have the same, and I guess this person's blue, so they're not the same individual, but someone in the same position, and you say, okay, great, nice to meet you. Let's put you on the waiting list. Let's put you on hold and just wait and see what happens. This purple arrow becomes the arrow kind of interest, because probably both these people felt okay. They probably didn't have any terrible lab problems or whatever. So if you can hold off and then you have a kidney transplant and you have an average outcome, how much further sort of down the road in time people would get. And so there's definitely some benefit to the individual, to society, to the payers in trying to time this appropriately, which is why I'd say, yeah, you can get transplanted too early, and you can, is that better or worse than being too late? So the other area of controversy I think is really important and obviously has gotten more and more deserved attention in this country and really across the world is the disparity in how we apply healthcare based, frankly, on what color people's skin is. And so if you look at the number, the percent of people who are transplanted preemptively, the blue line is people who identify as white, and the green line is people who identify as black, and then the other is seems like not the greatest phrase, but so this is a huge difference in the percent of what I just got through telling you I think is the best therapy. And associated with being transplanted is actually the mechanisms of getting to the wait list, and there's big disparities again by skin color and who's getting on the waiting list, because you can't get transplanted preemptively if you can't even get to the wait list preemptively. And this, I had to thank your society's scientific people sent me this, because this is hot off the press. I think it was actually either April or May of 2022. So this is people who have polycystic kidney disease, this is super small, I get that, but this is the odds of having a preemptive kidney transplant by skin color across these networks. If you're not familiar with networks, they're like a geographic distribution of the United States. So this would make up the entire country geographically. If all the dots were on this line, that would say it wouldn't matter what color your skin was, black versus white, everyone was getting preemptive transplants at the same rate. But look at this, all of the dots are to the left, which means no matter what part of the country you live in, you're less likely to get a kidney transplant if you're black compared to if you're white. And this is for people who identify as Hispanic, same pattern, or compared to white. So the odds are less all across the United States. And this is a huge, so the controversy becomes, if you have a therapy that you believe is better, but you know it's not being used, I'm just going to say fairly, should we continue to push it? And there have been people who say no, and who say, like, if this is what happens, then we should just cut it off and say you can't get a kidney transplant, at least a deceased donor transplant, preemptively, if this is how we're going to administer it in our country. So that sounds, I don't know, really severe. That's not quite the right word I'm looking for, but you can see an argument for that. And I think that's, I wanted to like bring that out. I'm just baiting people to get into the Q&A about this. So just to sort of conclude and see if it worked, I got some people to ask questions. Take-home points, chronic kidney disease, end-stage kidney disease are associated with higher mortality. And there's just a growing prevalence of people in this position, and it's expensive. And we all need to sort of think about how we're going to deal with this. Preemptive transplant is associated with better outcomes, and it is more cost effective. It's really not being done increasingly. I guess I took that slide out, but over time, we're not really doing a lot better at getting people transplanted preemptively. And there are disparities in the application of this therapy that I think are really important. And so barriers that we all need to be thinking about and trying to fix. I would still put this awareness of chronic kidney disease across the board at all levels, just trying to drive home the fact that how can we take care of people who don't know that they're sick, I guess. Promote early referral to nephrologists and to transplant centers, and then really kind of just keep trying to fix these problems that we keep finding where our delivery of care is not fair, basically, across different groups of people. And always, the way out of this is living kidney donation for any individual. As a group, as a large group, as a society, we have a lot of work to do with deceased donation. But when I tell people, like, how do you want to get out of this problem? It's to find a living kidney donor, as hard as that can be. So I think I made it. This slide, I think you've probably seen this a couple of times by now through the course of the last couple of days, promoting the registry, which I think is a great thing. And yeah, we made it. So now chat's going to light up, I hope.
Thanks a lot, Cliff. Lots of fascinating information there that I'm sure is going to present. We've actually got some questions already in the Q&A. Just ask people remain on mute if you wouldn't mind, and use the chat box, and then we'll get through as many of these as we can. So going back, when you were talking about the number of transplants, someone commented, do you think the increase in recent transplants has been due to the opioid crisis? And I'm guessing that refers to, more cadaver kidneys being available.
Yeah, absolutely. So, the increase in transplants is the result of a lot of things. One has been sort of trying to do our best to promote living donation. If you remember, the number of living donors was starting to come up a little bit. Also, the organ procurement organizations, which are really involved with talking to potential donor families and managing potential deceased donors, and then getting through the allocation process. There's been a lot of focus on their performance, and there's again entire weekends where it talks about the performance of OPOs. But yes, the opioid crisis has contributed to that, and it's trying to bring some positive out of an enormous tragedy. I would also say that the COVID pandemic was interesting because for many months there was a lot of hesitation about using organs from people who died from COVID. And sort of in retrospect, now that we think we understand it better, there was some lost opportunity, but some of just in the last 6 months, some of the surge in transplant has been from people who died from COVID. So the opioid epidemic obviously accounted for a much larger fraction than COVID, and the opioid epidemic is still going on. So,
yeah. Someone's asking about whether there are organisations campaigning to promote people to sign up to be donors on the in driver license. I mean, some people commented California's got I know Washington State has a program as well. Is there a national program that you're aware of
to promote donation? Yeah. So I mean, the Donate Life, like you see the green and blue, whatever flag, billboard, etc., is I think technically national, but yeah. I think it's disorganized. I think that as a nation, you can't drive down the street and not see something about heart disease or cancer. And I complain about this all the time because you don't see big billboards saying that kidney disease is a huge problem and we need to focus on donation. I would love to see that. I don't think that there's a cohesive national effort to drive home to the general public the importance of organ donation.
Yeah. So an interesting question here about the fistula first practice. What is the likelihood that it will be required if someone is a good candidate for preemptive transplant?
That a fistula be required? So that gets into some of the nuance, because when you think of that slide where I take a patient with a GFR of 19 who feels okay and their labs are otherwise okay, I really encourage them to do a couple things. One is to keep working with their nephrologist and keep like being assessed both by like labs and sort of like global health regularly, every couple months at least, so that we don't end up in a, because to be careful, still starting dialysis with a dialysis catheter is still bad, and nothing about preemptive transplant takes away the fact that starting with a catheter is bad. But if people identify a living donor and the donor gets evaluated and is sort of confirmed to be a candidate to donate, I will actually tell people not to get a fistula. It may make me unpopular sometimes with their nephrologist, because I think that we have control of as many variables as we can control at that point. And as long as everyone's sort of paying attention and communicating, I really think that you can consciously not get a fistula if you're prepared well enough.
So I got one here, and I've got no context on this question, so I'm just going to read it out verbatim. There was a recommendation from NAS report to eliminate wait time pre-dialysis to increase equity. What do you think of that?
Well, so that's what I was getting at. I've heard it in a couple of different forums. I don't know if I can make my slides go backwards. Let's see if I'm smart enough to do this. Sort of this here. So if someone is waitlisted preemptively, that means that they haven't started dialysis. But remember, you can be waitlisted and not have a GFR of 20. So not all of these people are accumulating waiting time, but let's just presume that these people are between dialysis and a GFR of 20. So they're accumulating waiting time, but they're not on dialysis. So what this slide is really showing is that a bunch of white people are accumulating waiting time more so than people who are Black or other race. And so the comments that have come out, which you have to kind of think about, because that is one way to fix this, is just say, well, you can't do it. So no one can get, so if we can't do it fairly, it's like being a parent. If you can't do it fairly, you can't do it. And just say you start accumulating waiting time and you start dialysis. And that way you sort of take away, but it would be a conscious, we would consciously be saying, we know this is good. Remember, people live longer, it costs less, it's associated with fewer rejections and what have you to be transplanted preemptively. But if we can't do it fairly, maybe it's worth it to just stop doing it. And the first time I heard that, I was like, that sounds extreme. And the more you think about it, you're like, maybe it's okay though. And I don't know the answer, but I think it's a really interesting thought.
And here's a great point we've got to hear, why not consider the fact that if you transplant someone when their person's at their healthiest, that they will end up with a better outcome?
Yeah, that's kind of my point about my stick figures, where my stick figures go. So that's the competing argument is, yeah, maybe this isn't so bad, but you don't really confidently move this line further to the right of this line. But it's never been done, it's been done a lot. It's never been studied closely to actually compare, because you can imagine, okay, take COVID vaccination. So a bunch of randomized trials. Some people got actual vaccine, some people got non-vaccine, and they compared them, see how they did. So you could envision a trial where you have a bunch of people that are randomized to do this and a bunch of people, but you'd never do that. You'd never get a trial like that to run in this country or probably anywhere in the world. But it's tempting. I mean, I see the logic, but I think that there's more emphasis on trying to maximize the use of your native kidneys. That's what we call them, native kidneys. And say if people are feeling okay and their labs are otherwise okay, then they're still doing okay. But you don't want to transplant them after they've gotten sick. So it becomes a little like playing chicken. you have to know when to swerve, and it's hard. And so the easy thing to do is to not play chicken against transplant people. I'm not sure it's the best thing to do.
Okay, we're starting to run out of time now, so I'm just going to pick a few from the list to put at you. If an identified live donor is older, so over 50 years old, then is this a factor in transplanting preemptively? If so, if the live donor that's been identified is older?
Sort of. I mean, I think that there's evidence that I have to be careful how I say it. I'm just gonna say it. So the worst approved living donor would be generally comparable to some of the best deceased donors. If you just think of like transplant course and transplant outcome, just because as transplant hospitals and living donor programs go, if we're actually worried about the person donating, either for their own health or for the function of the kidney, then we probably shouldn't let them donate. So the other piece of this I think is important, and I didn't study the agenda closely enough, but hopefully people have heard of paired kidney exchange. What our practice would be, because I think I'm envisioning the question is, well, what if you're 25 and your donor is 55? Like it's like child and parent would be a great example, sort of adult child and parent. In paired kidney exchange, we'd be like, great, so happy you have a donor. Let's go into an exchange and find another pair who's sort of in the opposite position where the parent, let's just call it, needs a transplant and the adult child wants to donate, and swap you. And that's so when paired kidney exchange started, it was all about like blood group mismatch and stuff like that. The idea of biologic incompatibility is much broader than the immune components of it. So we look at age just like everything else in terms of biologic compatibility. And I hope that answers the question sort of.
I think we've just got time for one more. Is there data on the demographics of what population finds out that they're in late stage kidney disease or kidney failure without prior warning? That's qualified, but is the relationship with the disparity in health insurance and inability to access medical care?
Across the board. Yeah, I don't have a slide about that, but it's across the board. So people from lower socioeconomic status, so like you look like zip code. So there's a lot of data based on like median household income by zip code. Zip codes with lower median income are referred later. They're more likely to start dialysis without pre-dialysis nephrology care. If you look at private versus public insurance, same disparities, skin color, it just sort of across the board, we can find these differences in delivery of care. And some sort of preemptive transplant just becomes one more in a litany of specific questions that you find that there's these differences.
Okay, we got through as many of the questions as we could. Apologies if we didn't get to yours. Any final closing comments before we close, Cliff?
I just want to thank everybody for sticking it out on a Saturday afternoon or evening, depending on which time zone you're in.